Joining us today for our webinar focusing on understanding your report cards, specifically your pathology and your biomarker reports. My name is Zach Getty, and I'm the Patient Education Program Manager here at Fight CRC. Fight Colorectal Cancer is the leading patient empowerment and advocacy organization in the United States, providing balanced and objective information on colon and rectal cancer research, treatment, and policy. We are relentless champions of hope, focused on funding promising, high-impact research endeavors while equipping advocates to influence legislation and policy for the collective good. So before we get started with the actual webinar, I have a few housekeeping items to go through. Bear with me as we work through these. We will have some time at the end of the webinar for general questions that you may have while the actual presentation is going on. Please feel free to use the Q&A panel on the right side of your screen to ask any that come up along the way. We absolutely will try our best to address all of them at the end. If your specific question is not answered at the end of the webinar, I do have a record of all the questions that have been asked, and I can get to you via email after the webinar has completed. We will have a webinar or a recording of this webinar available on our site in the next few days after this completes. If you have registered for this webinar, you will receive that direct link via email that you use to register for the webinar. And last but not least, feel free to tweet along with us using the hashtag CRCwebinar. Please remember to stop by our website at fightcrc.org to check out all of our patient and caregiver resources. This includes your Guide to Fight meetups, which are an online space to meet with other patients and caregivers. They're held 4 times per month and touch on a variety of topics. We have meetings for newly diagnosed patients, meetings to discuss hot topics, and more. Those are all virtual, online. There are various times throughout the week, various times throughout the day, so there's probably one that will fit in your schedule. Also, please check out our free Community of Champions app, which is a dedicated app that we have. There's also an online webpage for it. It's a place where you can connect with other people in the colorectal cancer community and to keep in touch with Fight CRC and what we're up to. And we also offer an assortment of print and digital educational resources that are free to request and download. A little disclaimer, the information and services provided by Fight Colorectal Cancer are for general informational purposes only. The information and services are not intended to be substitutes for professional medical advice, diagnoses, or treatment. If you are ill or suspect that you're ill, please see a doctor immediately. In an emergency, call 911 or go to the nearest emergency room. And Fight Colorectal Cancer never recommends or endorses any specific physicians, products, or treatments for any conditions. Okay, mouthful. Now, with all that out of the way, I'd like to briefly introduce our participants today. Joining us are Dr. Carmen Fong, board-certified colorectal surgeon and Fight CRC ambassador, class of 21, I believe, if I'm correct. And Dr. Rich Goldberg, Fight CRC board member, oncologist, and director emeritus of the West Virginia University Cancer Institute. With that, I'm going to hand it off to Dr. Fong and Dr. Goldberg so they can introduce themselves a little bit more, and we will get this webinar started.
All right, thank you, Zach. Thanks so much for having this webinar. I don't enjoy having this conversation ever with patients, but I always love the opportunity to, kind of educate and start having this discussion. But yes, I think I was an ambassador 2020, actually. It's been 3 years now. Recently moved from New York City, where I was on staff at the Mount Sinai Hospital. And now I'm in private practice in Decatur, Georgia, temporarily. But I'm pretty involved in national organizations, and I love working with Fight CRC for everything that you guys do. So yeah, so that's me in a nutshell. And so I'm going to start off today talking about the surgical pathology side of things. Is that right? All right, so for report cards, this is a little snippet of what we have in our most recent issue of Beyond Blue. And I just wanted to go over briefly what I'm looking for, and then what I tell my patients to look for when we discuss this. I always start with the fact that the staging of colon cancer specifically, but also colorectal cancer, can change during your treatment. So most of the time, initially, pathology reports are collected after the initial colonoscopy, of which a biopsy is taken. And so when a biopsy is taken, the cells are looked at under a microscope and the cells are graded. And you get a grade, and it tells you 2 things mainly. 1, the type of cancer it is, and then how aggressive the cancer is. The grade generally doesn't show up on the pathology It actually does for patients. You can actually see it will say well differentiated, moderate differentiated, or um, poorly differentiated. And that doesn't impact the surgery so much, but it does impact later the treatment. So I'm going to start there. So when I say that staging can change, you get a clinical staging when you first get diagnosed with a biopsy in your colonoscopy. No, after your colonoscopy. And I tell people it's kind of like if you take a muffin and you pick up a top of a piece of a muffin, you get a little sampling of that muffin, right? You get the flavor of it, you get a couple cells in it. But what you truly need after that is that you need to slice the muffin in half and see how deep the cancer goes. And that's what you get when you get after surgery, when the entire tumor has been taken out and it's sliced up and looked at under a microscope by the pathologist. So clinical staging is, again, determined by the biology of the biopsy, the imaging that you get, which is generally CT scans. So CT scans of the abdomen, chest, and pelvis to see how big, where the tumor is and whether it's spread. Whether it's spread to adjacent organs or to your lungs, actually upstages it, and then whether there's other risky features like enlarged lymph nodes and or tumors that are rather large and might be obstructing or kind of impending obstruction, kind of upstages things as well. So that's your clinical staging. The pathological staging is after surgery. And after surgery, most importantly, when I take out the tumor and the piece of the colon that goes with it, I also take out a piece of the mesentery, which is the fatty tissue that's around the colon, and that has lymph nodes in it. The lymph nodes at that point, generally we're told to take at least 12 to 15 lymph nodes, and if you have 12 to 15, it's considered an adequate sample. And having a few positive lymph nodes means that the cancer has spread to those lymph nodes. And at that time, your staging actually upgrades a little bit. So I'll start. So one more time to go from the bottom, because I know I talk really fast. So when I have a tumor in front of me in the OR, and say preoperatively we saw on the CAT scan that it hasn't invaded any adjacent organs, we're going to call it a 1 or a 2, right? A stage 1 or a 2. Stage 1, generally surgery is curative, and that's one of the reasons I went into colorectal cancer in the first place, is that you take the tumor out along with the lymph nodes. Generally, you don't need anything else. Once the tumor is out and I send it to pathology, and if any of the lymph nodes are positive at that point, it becomes upgraded to a stage 3. And then distant metastases, as you all know by now, are stage 4. But the lymph node status is really what determines whether or not you need chemotherapy afterwards. And I think Dr. Goldberg is going to go into this in a lot more depth. The one other thing I would add is that we generally lump colorectal cancer together. But the staging preoperatively and postoperatively for rectal cancer is a little bit different. So in colon cancer, generally we take it all out. You maybe get adjuvant chemotherapy or adjuvant any therapies afterwards. In rectal cancer, if you have a rectal tumor that appears to be larger or has involved the mesorectal fascia or the tissue surrounding the rectum at that point, you actually will get chemotherapy first these days to shrink the tumor so that the surgery itself, we actually have a better chance of getting everything out without taking too much out of the rectum. So yeah, I think that's that for now. So I am going to pass it on to Dr. Goldberg, and then I think a lot of this will be more answered in the questions at the end, unless you think I'm missing anything, Zach.
No, certainly. I do have a question, though. Is there a possibility for you to receive multiple pathology reports when it comes to like surgical pathology reports? Are you going to receive a new report every time you, like, let's say you have to have surgery more than one time and you have tumors that spread? Are you going to receive different pathology reports each and every time for that, or are you covered by one? How does that?
No, great question. So yeah, so you actually do get different pathology reports. So with the initial colonoscopy, with the biopsy, you're getting one pathology report. After surgery, you get a second pathology report. Sometimes that report gets, updated, whether when they send you the initial gross pathology, they've sliced it up, they've looked at it, but then they start doing the immunohistochemistry, like the fish biomarkers and things like that. And then that report gets updated. With subsequent surgeries, you will get other pathology reports. So I think the important thing for patients is that you're looking for one after every procedure where tissue was taken.
Can patients trust their own reports and look over them?
Absolutely. Like I absolutely would. And especially if you're moving around from hospital to hospital or from town to town, I would keep a copy of all the pathology reports because that plus the op report, the actual procedure, is probably one of the most important things you can carry with you so that any other physicians know exactly what was done. One other thing I thought I would mention is that people always ask me, why does it change? And I kind of explained why the staging changes, but is there any concurrence between like the clinical staging and the pathologic staging? And it's generally felt to be about 80%. So it's pretty accurate the first time when you have all your imaging and your biopsy, that it's like, okay, the staging will be about 80% accurate compared to the surgical pathology. The ones that are kind of different is that actually later staging is more accurate, like up to 93, 95%, where we see on the CAT scan that lymph nodes are positive or it's invaded into adjacent organs. So we already know that, the stage is going to be 3 or 4, where it's actually a little less accurate and tending to be more around the 40, 50% range is early staging because small lymph nodes that are affected might not be seen on a CAT scan. There are also patients who may never have a surgical pathology report and only have a biopsy report from the colonoscopy. And so in those cases, all the staging is done completely through the biopsy and then the imaging and then all the other clinical data like biomarkers.
Sorry, not to derail, but can you kind of expound on why they might never see a surgical report? Is it just taken care of if they had, let's say a polyp biopsy or a tumor biopsy during colonoscopy? Why would they not eventually see a surgical report?
Right. No. I mean, if they never have surgery.
Okay.
Yeah, if they never have surgery, you wouldn't get a surgical pathology report. Yeah, right.
Okay. Thanks, Ben. So for tumor testing reports and biomarker reports, with Dr. Goldberg to talk a little about this, just I guess what can patients expect to see on the report? What should they be on the lookout for? Really, what are the takeaways that they're trying to find when they get this report in front of them, or if they get this report in front of them?
Happy to address that. Let me introduce myself first. So my name is Rich Goldberg. I'm a member of the board of Fight Colorectal Cancer. And so I'm heavily involved in trying to get accessible information to patients, which is one of the main goals that Fight CRC has, and to support patients in their interpretation of all this complicated information that they get blasted with in addition to their diagnosis. I'm a medical oncologist, which means that I give drug treatments to patients. And colorectal cancer now is definitely managed by what we call a multidisciplinary team. And what I mean by that is you have surgeons, you have medical oncologists, and sometimes you have radiation oncologists. Sometimes you have interventional radiologists. And so managing colorectal cancer has gotten way better during my career, but it's also gotten way more complicated. It takes a village to manage this disease correctly. So we talked about pathology reports, and pathology is the way you make a diagnosis of colon cancer. You can make a presumptive diagnosis if you see a large tumor on a colonoscopy, but until the pathologist looks at it under the microscope, you don't know what you have for sure. While most masses in the colon are what we call adenocarcinomas, or cancers starting in the inner lining of the colon, it's possible that you could have another kind of cancer like a lymphoma, and the treatment is vastly different. In most circumstances, after a colonoscopy, you would go to surgery. The circumstances where you wouldn't would be if you had advanced disease, meaning spread to other organs, in which case we prioritize giving drug treatment over giving surgical treatment in most circumstances. So in some cases, all that the pathologist will get is a little bite of tissue that they look at under the microscope to make a diagnosis. And almost all colon cancers look the same under the microscope. They're moderately differentiated adenocarcinomas. And when I first started treating patients back in the 1980s, we really had one drug and we considered all colon cancers to be alike. Enter the era of genomic medicine and everything has changed. And it's changed in a good way. And it's continuing to change almost weekly, it seems like. And that makes an important point in that not always are doctors up to date in the latest changes. And so that's part of the reason we're trying to arm you with knowledge so that you can be sure that you're getting what you deserve and what you need to make an optimal treatment decision. So we talk about biomarkers, and biomarkers really are used in two ways. One way is that they can help us give a prognosis to a patient. So the whole staging thing that we talked about is a way of trying to segregate patients into categories so that we can try and predict how they're going to do based on the experience of patients that have come before them. And we have stage 1 patients who 90% are cured by just removing the polyp. And we have stage 4 patients where only about 15% are cured using today's technology. Although I would say 20 years ago, only 5% are cured. So we're gradually making progress and moving forward. And the pathology or stage is one predictive marker, but there are also other predictive markers, and I'm going to get into them in a moment, or other prognostic markers. Let me go back and say predictive markers help us decide which drugs to use. Prognostic markers help us to decide how a patient is expected to do on the basis of prior outcomes. So here's a sample biomarker report. And you can see that it's complicated. There are 3 things on the top: KRAS, NRAS, and tumor mutational burden. And each of these are markers. So I'm going to give you a little primer on what we call tumor promoter genes, as well as tumor suppressor genes. So the primer that I'm going to tell you is that a tumor promoter gene is like the accelerator on a car. If you have a mutation that promotes tumors, then cells are getting the gas. They're basically told to grow and divide. And those tumor promoter genes can be markers of the aggressiveness of the tumor. Tumor suppressor genes, when they're working, can stop tumors from developing. But sometimes those genes get mutated and inactivated. And in that circumstance, we talk about it's like having a car with a brake pedal that doesn't work. Instead of the natural ability to decelerate a pathologic process like cancer, if that problem develops, there's no way to stop it. And there are a whole bunch of different genes that are tumor promoter genes and a whole bunch of different genes that are tumor suppressor genes. And in fact, we're still unraveling the roles of the various genes, although we've made a lot of progress in doing that in the last 20 years. So let's talk about one particular gene. Let's go back to the last slide, the slide just before this. No, go ahead, one more slide. So I want to talk about on the right-hand side here, what's called tumor mismatch repair, DNA mismatch repair. So as you know, DNA is present in all of our cells, and when cells divide, the DNA unravels, and 2 daughter cells are formed. And then the double strand of DNA has to be rebuilt by the daughter cell. And that gives opportunities for there to be mistakes in the rebuilding process, which we call mismatches. And normally our DNA has the ability to repair mismatches, sort of like spell check on your Microsoft Word. Now, some people, those with Lynch syndrome, inherit a defect in their mismatch repair software, while others can acquire this defect. And when that defect is present, tumor cells will have lots and lots of mutations. And we've actually been able to exploit that because the immuno-oncology drugs that we use, like nivolumab and panitumumab and others, are able to ferret out cancer cells in a way that normally isn't true. They sort of uncloak the cancer cells, which hide from the immune system under many circumstances. But when you have this defect, either because you have an inherited mismatch repair defect, that's called Lynch syndrome, or an acquired one, then we want to know that because it changes the way we treat the tumor. Also, we want to know whether family members may be at risk. And it also has information for us on prognosis or outcomes. But it's most important use nowadays in treatment decisions is that it can predict the likelihood of responding to immuno-oncology drugs. And there have been some remarkable developments with this in that many patients who have advanced colorectal cancer will respond very well to these immuno-oncology drugs and can even be cured. And now we're even using them early on in some patients with rectal cancer, for example, or colon cancer. And the drugs can be so effective that you can get a complete remission of the cancer. And this has been shown in groups of patients with rectal cancer, so that you only need the drug. You don't need surgery or radiation in some circumstances. So this is a remarkable and unexpected discovery that's come with the use of these drugs. So in summary, why do we want to look for DNA mismatch repair? There are two reasons. One is to see if it looks like a person has an inherited predisposition to cancer, so that we can let their family members know that they could be at risk and could be tested. And the other reason is because it changes our treatment. Using these immuno-oncology drugs can be dramatically effective in these patients and keep them from needing chemotherapy or other treatments and have a great outcome. So next, I want to turn to these other genes here. You see RAS, BRAF, PI3 kinase, HER2, and TRK. So these are other genes that can be tumor suppressor genes or tumor promoter genes. And we can look to see if those genes are active and normal or if they've been mutated in the cancer. Cancer cells divide so rapidly that oftentimes mistakes in rebuilding their DNA occur and mutations can occur. And it's also important to understand that when you pressure cancer cells with drugs, you can sometimes cause new mutations to occur, just like what happens when you give antibiotics targeting infections. Infections can become resistant. And so sometimes it's important to actually retest tumors as we're moving along the treatment continuum to see if there has been a new change in the presence or absence of some of these tumor promoter or tumor suppressor genes. So let's focus on RAS genes, for example. It doesn't really matter what RAS stands for, other than to know that RAS genes can be drivers of tumor growth. And as a consequence of that, they can be prognostic, meaning that the about 45% of patients with colorectal cancer who have RAS gene mutations can have a worse prognosis, and they can be predicted. So let me go back to explaining the predictive part of this. So there are two particular drugs that we commonly use for treating advanced colon cancer that are very similar to each other. One is called cetuximab, the other is called Vectibix. Their chemical names are cetuximab and panitumumab. And we know from multiple studies that if there's a RAS gene mutation present in a tumor, that those tumors don't respond to those drugs. And you don't want to treat somebody with a drug that you can predict ahead of time isn't going to work for them because these drugs do have side effects. But if you do have what we call RAS wild type in your tumor, then we certainly want to consider using those drugs, one or the other of them, because they're interchangeable, as a part of the treatment plan. And so that's one of the ways in which this genomic testing can be really important. Now, RAS gene abnormalities are not known to be inherited, so these occur, they're acquired as a tumor grows and divides. And I would say that the other genes that are marked here are similar, but I'm not going to go into them in detail. But you can see that there are multiple different drugs. Now, one of the interesting things about this is that many different tumors will have either the same tumor suppressor gene that's been inactivated or tumor promoter gene that's been activated. And so now, for example, if we look at the bottom marker here, TRK fusions are present in many different tumor types. And so we now test for them in sarcomas, lung cancer, because the drugs that work against TRK fusions are tumor agnostic. It doesn't matter where the tumor started. They work across any kind of tumor type. So as I mentioned to you, this landscape is complicated and it's changing. And keeping up on it is hard for doctors, and I would say even harder for patients. So some of the literature that we've developed at Fight CRC to try and prompt patients to understand this, give you a mini course in tumor genetics and a list of questions to ask your doctors can be really important. And you can't just always assume that every doctor is up on all of these new findings because they keep changing from month to month. And that's good news because we keep making progress from month to month. Now, one last thing I want to talk about is a concept of something we call tumor-sidedness. Now, you may know that the colon is sort of shaped like an upside-down U in your body. The small intestine comes into what we call the cecum of the colon, which is in the lower right side of your abdomen. The colon then travels toward your head, makes a turn at your diaphragm, and then turns again to head down toward the rectum. And one of the things that we've learned over time is that right-sided colon cancers are different than left-sided colon cancers. Now, one of the reasons for that is that the right colon and the left colon come from different parts of the embryo. They're made by different tissues. And so there's a reason to explain why a cancer on one side might be different than a cancer on another side. But for example, we know that left-sided tumors are more likely to be RAS wild type and are more likely to respond to the drugs I mentioned, panitumumab or cetuximab, that are active in tumors that have RAS wild type or lack a RAS mutation in the tumor cells. So while I've tried to make this clear in lay terms, it's complicated. And understanding it, I takes work and also takes having educational tools developed that can make it understandable. Because often when we're in the office, we're running through this in a way that can be confusing to patients. Even though it is confusing to patients, it's worth it to study up on this. So I'm going to stop there and turn it back over to Zach.
Thank you so much. I would like to go ahead and open it up for questions. If anybody watching the webinar has questions, please feel free to type them in the Q&A panel. But I myself have a few questions, if you don't mind. So, Dr. Goldberg, you mentioned sightedness and how that impacts perhaps the drugs that might be chosen to use for a specific tumor. Does the sightedness of a tumor have any impact on surgical outlook, Dr. Fong?
Yeah, I knew you were going to ask that question too, as soon as you said that. So right now, as it stands in the ASCRS guidelines, there's actually no difference between how we would approach surgery if surgery is required. So for a right-sided tumor, we do a right hemicolectomy or an extended right hemicolectomy, depending on where exactly the location of the tumor is. And then for left-sided tumor, we end up doing either, left hemicolectomy or single colectomy. The only difference I would say is generally the distance of the tumor to the rectum is the only thing that has somewhat of a surgical implication, because the closer it is to your rectum, the more concern there is that it becomes a more extensive surgery. And then obviously if it's in your rectum, we're talking about something else entirely.
Thank you. So it's safe to say that if you have a rectal tumor, sightedness doesn't really apply to that situation. Or
correct.
Left-sided. Okay.
Yep. Yep. Mm-hmm.
Thank you. So when discussing biomarkers, I know you talked about staging, Dr. Fong. Dr. Goldberg, are all stages of colorectal cancer, will those patients have their biomarkers tested? If you come back stage 1, are you going to be tested for certain biomarkers, or is this a stage specific and independent type of thing?
So generally speaking, stage 1 tumors are so likely to be cured. Often they can be cured by the colonoscopist just by doing a polypectomy, if the polyp is what we call a pedunculated polyp. A pedunculated polyp is shaped sort of like a mushroom. And when the colonoscopist goes in there, they can put a snare around the base of the mushroom and clip the polyp off very close to the wall of the colon. And often that's enough to cure people. So in that circumstance, you probably wouldn't do biomarkers on that. The one exception to that would be if a colonoscopist goes in and sees lots and lots of polyps and suspects that a patient may have an inherited predisposition to cancer like Lynch syndrome, then you would want to do a biomarker on that, which would be the microsatellite instability testing that I mentioned. For stage 2, 3, and 4 tumors, we do commonly do biomarker testing, again, to try and identify patients with Lynch syndrome, also to try and determine if the patient has a bad biomarker, like a RAS mutation that could portend a worse prognosis. And certainly for stage 4 tumors, when we're managing our drug treatment decisions, the biomarker testing is really important. And you may even find that your doctor recommends rebiopsy for repeat testing during the course of management of stage 4 advanced colon cancer.
So you might have multiple biopsies for stage 4 cancer for purposes of determining your biomarkers.
And whether they've changed over time.
Interesting. Thank you. I do have a couple of questions that have come in. Does transverse colon cancer act more like right or left-sided colon cancer?
You want me? So I'll go first, but then I think Dr. Goldberg has probably a better answer. The transverse colon Dr. Goldberg mentioned the upside down U shape. So generally, we go by whether it's closer to your splenic flexure or your hepatic flexure. So on both sides, you have the liver and the spleen. And there's, unless it's right in half, right in the middle, which it generally isn't, it's usually more towards one side or the other. And I find that splenic flexure is going to be more left-sided and hepatic flexure is more right-sided. Embryologically, do you want to answer that one, Dr. Goldberg?
You can go ahead. You're on.
No, I was going to say embryologically, technically, that it should be more left-sided. They act more like left-sided cancers.
So one of the points I would make is that transverse colon cancer is much less common for reasons that we don't really understand than is right-sided or left-sided. And the way that I would look at a patient with a transverse colon cancer would be to use the biomarkers to help guide me. So if that tumor had a RAS mutation, then I would not tend to use the cetuximab or panitumumab. I would treat that patient instead with a drug called bevacizumab or Avastin that attacks the blood vessels that grow into tumors. And so that you would treat them more like a right-sided tumor. So it's a bit confusing.
No, that's a great question. Yeah.
Thank you. I have another one, and this will probably be more towards Dr. Goldberg's specialty, but I may have some touch on surgery as well. What is the step-by-step process you would go through during your treatment plan considerations? Would you look at sidedness or biomarkers first? As I assume the person asking this probably means like which weighs more heavily on treatment plan considerations, the sidedness of your tumor or the biomarkers present within the tumor?
So you would look at all of them together. So, you get sidedness at the time of diagnosis generally because the colonoscopist says, oh, this is a right-sided or this is a left-sided cancer. And you get biomarkers usually at the time that the surgeon removes the bulk of the tumor if you're going to have surgery done. And we factor all these things into an equation when thinking about how to individualize patients' treatment. There are other things we look at that we didn't talk about, like whether the tumor invades into blood vessels or whether there are tumor deposits around the outside of the colon, whether it invades into nerves that are around the outside of the colon. We kind of integrate all of this data to try and come up with a prognostic assessment and then take that the next step to decide on treatment recommendations. Thank you.
So I'm going to continue with some questions that we had. I'll give a few more minutes for people viewing the webinar to ask questions, but I want to be respectful of everyone's time here. When during treatment should patients expect to see pathology and or biomarker reports? I know obviously pathology is probably going to be, you have clinical pathology and the surgical pathology. I would assume that'd be after your surgery is complete and after it's gone to a pathologist. When in your treatment would biomarker reports start to play into what's going on?
So nowadays, when we're looking at the immuno-oncology drugs, we want a biomarker assessment of, at least of the microsatellite instability, whether or not the tumor has normal spell check right away. Because, for example, if you have a patient with a rectal cancer and you find out that that tumor has defective spell check, then that patient might be eligible for a clinical trial that uses an immuno-oncology drug, or the multidisciplinary team might consider using that drug even outside the context of a clinical trial because of the results from a big study at Sloan Kettering and an even larger study that's underway now that shows such dramatic results, allowing patients to avoid surgery and radiation in that circumstance. Often the other biomarker testing is done by sending the tumor specimen out to an external laboratory. And that external laboratory will look for many different abnormalities, often 500 to 600 genes that are known to be tumor suppressors or tumor promoter genes. And that's generally done at the time that the surgical pathology specimen goes to the lab. So for that kind of testing, it tends to be a little bit later. And that's the same kind of testing that may be repeated later on in the course of management of advanced colon cancer to see if any of those 500 to 600 genes have changed over time. While we have a limited number of genes for which we have a specific treatment today, we're constantly doing trials of new targeted approaches that affect specific gene abnormalities. And so one of the reasons for doing that is to allow people to get into clinical trials that may be particularly suited to the abnormality that's present in their tumor. But for some reason, we can't hear you, Zach.
Are you on mute, Zach?
I muted myself. My apologies. I'm saying I have a couple more questions. Dr. Fong is typing an answer. After she's done responding to that one, I will read it out loud on the webinar so people have the advantage of seeing an answer that are viewing later. But another question is, you mentioned that things changed almost weekly when it comes to treatments. What is the best way for a patient to keep up with all this constant change?
So it's difficult for us as physicians, even for me as a person that's almost entirely focused on GI cancers, to keep up with all the changes. I'll give you an example. The European Society of Medical Oncology just met last week, and doctors from all over the world were in Madrid, Spain, and they presented new information as well as updates on clinical trials. And all of us that are in the field get all these news feeds, just like everybody gets news feeds on what's happening in the world. We get news feeds on what's happening in the world of oncology. And so, my emails have been coming in from the new results that have been discussed at the so-called ESMO meeting. We have the American Society of Clinical Oncology has 2 meetings a year, one that's just for GI oncology in January, another that's for all cancers in June, and that's where we get the latest data. Now, often this latest data is presented as what we call an abstract, which is just a 200-word summary of what's going on. And we all wait to see the real papers that come out in the literature, because those are reviewed by other doctors to be sure that the results are well presented and accurate. And so keeping up on that is complicated. But for example, Fight CRC will look at what's going on in these various meetings and will post information when there are important updates for patients to know about. One of the difficulties, of course, is being able to put these things in context if you're a patient. Because if somebody says, okay, well, we've got a new treatment that looks promising in people with a SMAD4 mutation, you have no idea what to do with that information. But Fight CRC does try very hard to let people know when there are treatment changing decisions that could be important to them.
We do try to stay on top of that to the best of our ability and make announcements when we can. So you can always follow us on our various social channels for that kind of information as well. So let's see here. I'm going to just read a question out loud that was answered by Dr. Fong. The question was, when, if at all, should you ask about getting an updated pathology if you are not having any surgery scheduled? And also, second part of the question, why do some stage 4 get their colon tumor removed surgically right away and others wait until later, if at all? And the answer follows is, for the second part of the question, the current surgical guidelines allow that asymptomatic stage 4 colon cancers get treated with medical therapies first before surgery. Generally, when the tumor is symptomatic, obstructive, or perforated, it is removed surgically first. You can also have small colon tumors and liver mets removed at the same time in select situations. And we did also do a blog about stenting as a bridge to surgery for obstructed colon cancers that need chemotherapy before surgery. And I actually remember that blog. Thank you, Dr. Fong. That is, you can find that on our website. It's actually very interesting. That was something that many of us were unaware of was an option when that study came out. So it's a very informative blog. It's very interesting. I do have another open question here. If using ctDNA, circulating tumor DNA, and some genes have changed due to chemo, will it still show positive? And I'm assuming that is presupposing that you may have some gene changes due to chemotherapy. Is that the case, or?
So let me talk a little bit about ctDNA. So you remember DNA is a genetic code that we all have in every cell in our body. To remind you, cancer cells mostly have the same DNA as we do, but their DNA is modified to make them malignant. And we now are developing sophisticated techniques so that we can detect DNA that has gotten into the bloodstream when tumor cells have tried to travel to other parts of the body. And we call that ctDNA, or circulating tumor DNA. And the nice thing about that is you don't need a biopsy to detect it. It can be detected by just doing a blood test. And many of the companies that are offering this kind of testing, which is brand new, is just really surfaced in the last 3 years, will actually profile the primary tumor, find the genetic abnormalities in the primary tumor, and then look for them in the bloodstream. So they aren't going blind, they know what they're looking for. And we can use ctDNA in several different ways. So for example, in somebody who has a ctDNA test done after their diagnosis and it's positive, then has surgery and chemotherapy because they have a stage 3 cancer for which there's a high risk of recurrence, we can look and be sure that there is no ctDNA in the bloodstream. And that can be useful to us. And if we detect ctDNA in the bloodstream, then that makes us look for signs that the cancer has come back. And there are even clinical trials now that are being done to try and treat patients, even if you can't see the cancer, if their ctDNA turns positive. You also can use that ctDNA to monitor response to treatment. So for example, if somebody has liver and lung spread of their colorectal cancer, you can use the ctDNA rate of rise or rate of fall as a way of knowing whether your treatment is working or not. So you want to see the ctDNA levels come down. And if you see them start to go up, then if there's a trend there, then that suggests that you may need to treat with a different set of drugs. The nice thing is no need to do a liver biopsy or a lung biopsy to track the tumor DNA. And you can also track whether there are changes occurring in that tumor DNA using what you obtained from a blood specimen.
Interesting. And then someone has a follow-up question about how does ctDNA differ from CEA?
So CEA is a marker of colon cancer that is normally present. It's a protein that's normally present in low levels in the body. And about 60% of colon cancers will produce CEA, so that CEA levels will go up if there's colon cancer in the body. So we can use that as a tumor marker. And again, we plot the direction of change of CEA. So CEA goes up or down. CEA is not a genetic test. It's a test that looks at a protein. DNA is a genetic test. DNA codes for proteins, but it is what proteins are made from rather than protein itself.
Thank you very much.
I think there was the first part of one of the questions that wasn't answered yet. Tim's question about updating. Where was that?
It was
updating pathology.
Yeah, the first part of the question was when, if at all, should you ask about getting an updated pathology if you are not having any surgery scheduled?
Yeah, I was just going to throw in there. Generally, that happens during surveillance, surveillance colonoscopy. So, if the gastroenterologist or the colorectal surgeon is doing the colonoscopy, they will do it during surveillance, which tends to be during the first 5 years, every year or so. Some people will actually do it 6 months after the first colonoscopy just to see if there's any changes. And then I guess if no, that's it for now. I was going to throw one thing in there that Dr. Goldberg mentioned about the pedunculated polyps and having that removed entirely during colonoscopy, is that just to confuse us all further, you can actually have polyps removed via EMR or ESR, which is endoscopic mucosal resection or endoscopic submucosal resection, where the entire muffin is removed versus just a piece of it. And in those instances, if the entire muffin is removed, the entire tumor is removed with a 2 millimeter margin, it is considered curative. But then, as I had mentioned during the TNM staging, in colon cancer is staged based on the depth of the tumor rather than the size. If you have other things such as high-risk features like lymphovascular invasion or peripheral neurovascular invasion, like poorly differentiated tumors, high-grade features, then there are instances in which our guidelines right now, you might end up with surgery anyway.
Okay.
Yeah.
Thank you. Thank you both so much for taking the time to answer all these questions. I do want to be aware of the time and respectful of everyone's time that they get here. We are getting some thank yous in the chat, so thank you both. I do want to take a moment to plug some of our biomarkers resources here for anybody that may have any questions. Fight CRC does produce a biomarkers brochure. You'll find a lot of the information that we discussed in here today, although not as in depth, but it's a handy resource to have on you if you have any questions. And we also are in the process of updating our biomarker content on our website. So if you have questions about specific biomarkers, what they mean for your treatment, what they mean for your prognosis, our website is being updated as we speak, so it's a good place to look, and that's just fightcrc.org. As part of this biomarker brochure, it does include a perforated card we call a biomarker passport that you can punch out. It has many of the common biomarkers that are found in colorectal cancer on there, as well as some other information that's handy to have. We suggest that you use this, you punch it out of the brochure, you take it in with you to your physician's appointments, you discuss with them what your biomarkers are. You can hold on to it. It really can kind of just help you keep track of your treatment. And in case you have to change facilities, change physicians, it's a good place to move, or it's a good thing to have on you at that time. So in addition to those, we are currently launching, as of today, on Community of Champions, which I mentioned earlier, is our app, and you can also access it via the web, Biomarker School. So this is an interactive quiz that you can take to test your biomarkers knowledge. We've tried to make it as fun as biomarker content can be. So if you're interested in seeing what you picked up from this webinar, what you know about biomarkers, please visit Biomarker School in the Community of Champions app, which is available on both iPhone and Android, or at community.fightcrc.org. I would like to take a second to thank both Dr. Fong and Dr. Goldberg for volunteering their time. Thank you very, very much for taking time out of your busy schedules to answer some questions and be with us today on this webinar. I'd also like to thank Amgen for their support in making this webinar possible. Fight Colorectal Cancer's mission is we fight to cure colorectal cancer and serve as relentless champions of hope for all affected by this disease through informed patient support, impactful policy change, and breakthrough research endeavors. Please keep an eye on your inbox. If you'd like to watch this webinar again, you'll be getting a link to the post on our website and YouTube in a day or two time. And if you registered and were not able to attend live, you'll be able to view it like that. So thanks again to everybody who joined us, and a big thank you to Dr. Fong and Dr. Goldberg. Thank you so much.